Hey folks, welcome to EMS Challenge. We're live at Gardendale at the Civic Center. Thanks for hosting us today. We really appreciate it. We got Dr. Willet-Caldwell, one of the EMS fellows, who will be doing the lectures this morning from 9 to 11. If you're in the area, come out, train with us. We're going to be doing some advanced airways, some mega code scenarios. We have the new ultrasound. How do you pronounce that name? You know how to say it? What's it called? Hocus. Oh, no, that's not it. I thought it was like that movie Hocus Pocus or something. Anyway, we got a new ultrasound. We don't sell these things, but we got an ultrasound that kind of has artificial intelligence. It labels things for you, so it's pretty cool. We'll try play with that some this afternoon as well. But skill labs from noon to 2:30. So we're at the Gardendale Civic Center. Just a few regional updates before we get started. For the folks that are doing training at the regional level, you know, the state says that the regions can accredit EMT and advanced EMT training. So I know a lot of folks are doing those. I'll just advise for the areas that are doing that, please remember that EMT, we used to call it basic EMT, is no longer basic. The scope of practice for these guys is really out there. They can do advanced airways, they can do iGels. If you have a ventilator, they can do CPAP or BiPAP. If you have access to capnography, they can do that. The EMT is the backbone of pre-hospital care. So for you as the medics, please make sure you're training your EMTs that you're working with. As the new EMTs come up and start working with you, realize they're getting more and more responsibility. So we just got to make sure we're training these guys appropriately. Without them, we're going to fail. But scope of practice for the EMT level, again, we're doing things that are not being done other states as far as some of the stuff, airway management, iGels, etc. The advanced EMT, I know the new protocols came out back in April, but remember the advanced can do epi for cardiac arrest. There's some shortages of epi. Sometimes you got to make your own 1 to 10,000. So as a medic, make sure you train your advanced guys. These guys can really do a lot of things now. They have a long list of medications. They can do TXA and traumatic arrest or trauma situations. They can do Toradol, they can do steroids. So again, it falls back, unfortunately, on you, the medics, to make sure the advanced EMTs are getting what they need so we can make sure these guys are doing a good job. And then obviously at the stations and agency level, we got to keep doing our Con Ed. Thank you for choosing EMS Challenge today. The lectures are great. The more important thing is the skill labs where you can ask the doc questions. We can get to know each other again like we did years ago. And we can kind of work on skills. That's where we kind of make a difference here. So please, if you're in the area, come out and train with us. Some friendly reminders, 12 leads. If you're doing 12 leads, do them early and often. We had the MDAC yesterday. 5 out of 15 patients that we put in on the last run round that the EMT called STEMI was a STEMI. The other 10 were abnormal EKGs that got evaluated. But the point of that is, of the paperwork we got back from the hospitals, 5 people survived, had a cath, had a great outcome because of EMS recognition of a 12-lead STEMI that the machine did not. That's 5 people that was sat on the wall and died had you not done a good job. So thank you. That's just the BRIMS region right now. Capnography. If you intubate somebody, place a tube, you got to have waveform capnography documented in the narrative that you see a waveform and a number. If you don't, there's no defending that in the court. Nobody survives an esophageal intubation. So make sure we're using capnography. For the medics, if you're using an iGel or a King or AirTrack, whatever blind insertion device you got, as a medic, capnography goes on those as well. If you don't have capnography, it's not working. Epi dosing, there's some changes coming out. So there's some places that are doing epi, a milligram in a 250 bag and running it during cardiac arrest. Some folks are spacing out the epi. There's some blogs out there saying we don't even use drugs in cardiac arrest. In my opinion, first dose of epi should be quick as you can. All right, you're doing the ABC, starting compressions, defibrillation if you need it. First drug is epi, and then after that, if you want to space it out to every 5 minutes or so, that's fine. But epi is still important. And the big other thing I wanted to mention is Narcan use. Remember, nasal Narcan does not work in cardiac arrest. They have no pulse, the airway management, and epi, not Narcan. And Narcan, IO Narcan, the only time you should be giving somebody Narcan through an IO is if they're unresponsive, respiratory arrest, and you can't manage their airway with basic maneuvers. Then you drill them for Narcan. Otherwise, just manage the airways. All right. So those are friendly reminders. These are the not so friendly reminders. Esophageal intubations still occur. No one survives. If you've been intubating long enough, you'll put a tube in the esophagus, but then you recognize it and you pull it out. If you're not convinced the tube's in the right place, pull it out. There are web pages, there are lawyers that do nothing but look for this stuff, and you cannot defend a missed esophageal intubation. So thank you for almost smiling. All right, good. Updates, we're here today. We're in Oxford, end of the month. The State EMS Conference is 1st November. The SMEC meeting is that Monday. If you have anything you want to discuss, come on down there. There's a town hall that morning. In December, we're at Springville, and that's all I got, and I'll leave it to Dr. Willett. Questions, comments, statements within reason? Sweet. That's for you, man.
Thank you, sir. And thank you, sir. Which one? This one. Yeah, that's first. Perfect. Thank you. Good morning, everybody. Thank you for coming in person, and thank you to our folks that came online. I am Melissa Willet-Caldwell. I am an emergency medicine physician, and I'm one of the EMS fellows. I'm working with Dr. Ferguson this year out of UAB Medical Center. So today, we are going to have 2 one-hour lectures. We'll give you all a break in between so you don't get death by PowerPoint. But the first hour is going to be trauma systems of care, trauma field triage. The next hour will be mass casualty incidents and MCI triage. We'll talk a little bit about the structure of incident command and a little bit of history about it as well. So I talk pretty fast. I'm from the north. So if I'm talking too fast, if I'm not talking loud enough, which very rarely happens, or if you have questions, just interrupt me anytime, okay? And thank you guys all for coming and for hosting us. I live in Gardendale, so I'm y'all's neighbors. So it's nice to meet you guys. Okay. All right. So topics. Trauma system organization and facilities. We'll talk a little bit about what makes a level 1, a level 2, a level 3. We'll talk a little bit about communications and emergency response, which is y'all. A little bit about medical oversight, which is Dr. Ferguson, myself, Dr. Blake Davidson in the back there, who's another EMS fellow. We'll talk a little bit about data collection and injury prevention, which is a big part of trauma. And then at the end, we'll wrap it up with field triage, okay? So, trauma system organization is an organized approach to managing acute traumatic injury. The World Health Organization criteria and requirements for a designated trauma system include pre-hospital care, which again is obviously y'all, education and training, facility-based trauma care. So once you get to the hospital, what do we do? How are we ready? And then quality assurance. So collecting data and implementing quality improvements, both at the local level, but also regional, state, things like that. So most standards of trauma system organization and treatment is outlined by the American College of Surgeons and the Committee on Trauma. And I'm not sure how to say that acronym. It makes me want to say ASCOT, but I don't think that's correct. Trauma system organization, so requirements for pre-hospital care. You have to have formal oversight, right? You have a universal access number, and there is also regulatory legislative mechanisms in place. So meaning locally, what we do is defined at a higher level, right? They pass legislation that kind of informs what we do. And then you also need education, which is what we're doing now, right? You need training standards so everybody knows what our protocols are. We're doing things the same way and we're doing them well every single time. And then licensing and renewal requirements for y'all. Most states have a trauma advisory committee. We are no different. This provides oversight, provides advice to the state trauma office, and this is related to systems improvements. This assists with how the funding that we get is distributed. And then in Alabama, BRIMS is the lead agency. We work very closely with the Alabama Department of Public Health and the Office of EMS and the State Board of Health. So in Alabama, the Alabama Trauma System, right, there's a, you guys know all this, there's a centralized communication center, right? So the Alabama Trauma Communication Center, it monitors the trauma resources of all available trauma centers in our region, right? So at minute by minute, it knows who's on diversion, who has what resources available. You know, they will help route you to the appropriate hospital based on the information that you give them about the patient, about the scene. And then you can read this. I won't read it out loud to you, but this is straight off the BRIMS website, the goal of the Alabama trauma system. And this is truly the goal of most trauma systems, right? We want to meet all of the minimum requirements that are set forth to us, and we want to even exceed them if possible. So participating hospitals, they must have an organized response system, right? And this is at several levels. Predetermined equipment and facilities available, right? So you have to have appropriately trained and committed personnel, emergency medicine doctors, staff that are advanced trauma life support certified. You need, ORs available depending on what designation of trauma center you are. There's a Belmont in there, right? We need the right equipment. We need to be able to efficiently take care of these patients. We need to be trained. We need to be ready. So a level 3 trauma center, right? So rapid trauma assessment, resuscitation, stabilization. This happens in the emergency room. This is usually emergency medicine doctors that are doing this, but not always. They have to be integrated into a larger regional system, right? And we have to have transport agreements already in place, because this place is probably not going to give the most definitive care should someone accidentally be routed here instead of a level 1 if they need it. All facilities within the trauma system have to do local community outreach of some sort. So this is, bike safety, helmet safety, gun safety, things of that nature. So to be a level 3, you have to have a general surgeon on call, not necessarily a trauma surgeon, just a general surgeon. And then orthopedics, radiologists, and anesthesia on call. So sorry, general surgeon immediately available, meaning in-house. They have to be in-house. They can't be 15 minutes away. And then the other 3 services have to be on call as needed, determined by the general surgeon. So for level 2, the same things as the level 3, but also you have to have trauma surgeons available, not just general surgery. And they have to be available within 15 minutes of the patient's arrival. And then, as you can see, there's a lot more specialty services that have to be made available to the patients, right? So like Baptist is a level 2 out in Montgomery. There's a lot of level 2s that we have in our system. And then a level 1, this would be UAB, this would be Mobile, this would be Huntsville. So they do obviously rapid trauma assessment, resuscitation, stabilization, all the same things that the level 2s, level 3s do. But they are supposed to be kind of the flagship hospitals. So they do a lot more with educational outreach, community service. They have to have a full-time injury prevention coordinator who helps them to do these things. Trauma surgeons on, at the hospital all the time. They sleep in the hospital. They're there 24 hours a day. They actually respond to the bay for level 1s. They have to be there within a certain amount of minutes for a level 2 activation. All the same specialists, all available. And then they also have to meet minimum numbers of patients that they treat per year, and patients that they treat or that they admit with an illness severity score that is on the higher end of the spectrum. So we just need to make sure we're staying up to date and having our skills sharp by treating a certain number of people, having a certain number of trauma activations. And then they have to have a surgical residency program and provide ATLS courses and conduct trauma research. So research is a big part of the trauma systems. So a level 4, so this is really a stop along the road. They have very limited resources available, but they should be staffed by someone who is at least ATLS certified. If your patient needs an airway, right? If your patient needs a chest tube, patient needs something, and you don't have the time to get to a higher level of care, these are just a resuscitation point along your way. So communication and trauma. This is super important. These folks gather scene information from you. They will, or from whoever calls in, right? They will gather it from bystanders who call 911. They will dispatch the appropriate providers based on what bystanders are telling them. They can give bystander instructions. In some systems like ours, once y'all get on scene and you give information, they can help route you to the most readily available, closest appropriate level of care. And it connects y'all to us who are sitting in the hospital waiting on you guys. So we know what's coming. And that's very important, right? So we really like having a little bit of a heads up, because it takes a minute to kind of get everybody, get all the residents, get all the attendings, get all of our equipment. We'll prime the Belmont, for blood delivery. We'll get, based on vitals and mechanism, I'll get equipment ready, I'll have chest tube stuff ready, I'll have central line stuff ready. So sometimes we get a here now trauma, and that happens. We'll get a GSW from the front of the hospital. That happens. People come, POV, patient's own vehicle, but it's always feels a little bit more disorganized than when we kind of are, everybody's amassed and ready to go. So the emergency response, right? And that's part of the communications, is making sure that we are getting the right patient to the right place in the right amount of time. And this is you guys, right? So this includes appropriate triage in the field, which is not always an easy thing to do. Stabilizing procedures in trauma as needed, right? So does the patient need an airway? Do we need to needle decompress the chest, right? And then deciding air versus ground. Those are very important decisions. So medical oversight. These two fine-looking gentlemen up here. Berg, you look very happy that I put this picture on. The one of Robinette looks even better. So these are some medical directors, right, in the red phone. So direct is in person, right? So when we ride along with you guys, when you use, by radio, by telephone, when you call and you want to ask questions, what should I do? Can I do this? Indirect is obviously standard operating procedures, protocols, treatment guidelines. The shift is more towards indirect because it takes time. It takes time to call us, right? And we know in trauma, the most important thing is getting them to the appropriate facility, right? That's what saves lives in trauma, getting them to definitive care. Very different than cardiac arrest, where we want you to stay. We want you to stay and we want you to work it, right? Because the things that you do on scene are the most important. You guys are going to save that life. Instead of a trauma where they typically will need a surgeon, right? They need some sort of surgical stabilizing procedure that they can only get at the hospital. So EMS, this is my opinion, but literature also supports that EMS is best served by an EM physician, right? So other specialties, they may not be familiar with all the procedures that we're asking you guys to perform in the field for these patients, right? They may not have a good understanding of EMS and what the field is like, the unique difficulties that you guys encounter, right? I think trauma surgeons can do this effectively for trauma patients, but they don't intubate and they don't do all the procedures that we do, like you guys. So we work very closely with trauma surgeons when it comes to managing traumas outside of the hospital, but I think EM and EMS trained ideally are the best ones to help y'all. So medical oversight also does focused education, like we're doing today, and training, like skills labs that we're going to do later today, feedback and QI. So when we are riding along with y'all, we may debrief about, whatever happened during the call. We review charts and we kind of go over things like, what are we doing that's great? What are we doing? What could we be doing better, right? That's all part of this. So audit filter examples. So when we are looking at pre-hospital trauma care, these are just some examples of some things that we look for, right? So filters, when we're kind of flagging them, things that we would want to address and correct. And then data collection, right? So this is an essential component of the trauma system. I'm not a big researcher. It's not my favorite thing, but I do recognize the importance of it. So data is pooled regionally and nationally within trauma systems, right? So we look at patient demographics, we look at, certain specifics of the scene about how it was triaged. Did it go to the appropriate level of care? Why not? What stabilizing procedures needed to be done? All those things. All that data gets pooled, right? And this really helps to inform system improvements. Like a good example was in penetrating trauma, we don't put patients on backboards, right? So if somebody, and that's because, right, if somebody has, if their cord gets transected, right, gets disrupted by a ballistic, by a gunshot, by a knife, that's the damage is done, right? Putting them on a board isn't going to really make a difference. But those patients, they also have problems with bleeding. They also have problems with breathing. And putting them on the board might make that worse, right? It often does, okay? And it can delay scene time, right? So those are things that we figure out, and we only can through large numbers of patients entered in the system, where we can look back and look at their outcomes and compare it to what was done in the field. And it informs how we change our protocols and change our management. So while some of us may find it a little burdensome, cumbersome, don't enjoy it, it really is very important. And so under versus over triage is something that we talk a lot about in trauma. So under triage means you underestimated the level of care that a patient needs, right? So say a patient had a fall, maybe they were on a blood thinner, we didn't realize it, and they're bleeding into their brain, right? But their vitals are stable. Maybe they got a GCS of, 14, right? Not 13. So they get taken to, say like a level 3. I don't know. It's unlikely this would happen, but say it did. That person is not going to be able to receive the definitive care. There's no neurosurgery there that they can receive care from. So that's an example of under triaging, right? So we did not recognize the severity of injury and they went to the less appropriate place. It delays care. Patients have worse outcomes. Okay. So the American College of Surgeons and the Committee on Trauma they like to see an under triage rate of less than 5%, right? Because the most important thing to us is having good outcomes for patients, right? And if we're under triaging too much, we're having bad outcomes, right? So that's under triage. Over triage is the other way around. So you're overestimating the level of care that somebody needs. So say that same patient bumped their head, maybe their GCS is 13, they go to level 1, and they have no injuries, right? That's an example of over triage. They're not bleeding into their brain, they just have a concussion, okay? So they went somewhere where they didn't need that specialty care, but in the field, we didn't know that, right? And so we say an acceptable over triage rate is 25 to 35%, right? Which is a lot higher than under triage because we'd rather be safe rather than, right? Does that make sense to y'all? Okay. And as under triage rates go up, over triage rates go down and vice versa, right? All right.
Hey, I'm gonna throw in a question. So out here at Gardendale, y'all don't transport, correct? Y'all want to? Nobody's gonna answer that question. That was a joke. Sorry, guys. Do y'all put the patients in the TCC yourselves from scene, or do you let the transporting agency do it? Go ahead and get the ball moving. Yeah, that's very important because the problem we see now, just like staffing in EMS, staffing in the hospital is pretty tight, as are beds. I don't know if y'all noticed, even children's was on diversion here recently as well. So every hospital is overloaded. So early system entry gives us a chance at TCC to figure out where we need to go. I mean, really, you overcall than undercall. Absolutely. Remember, there's the EMT discretion, and we saw this just last week where an EMT had to gestalt this patient. Something wasn't right. They were hemodynamically stable, pretty significant mechanism of injury. They put them in the system. The level 1 in the area was on overload, so they went to a different facility. But by the time they got there, the patient was beginning to deteriorate. But they were already in the system, so we can make a rapid transfer from one hospital back to the trauma center with that. So early system entry, recognition of these things makes a big difference for us, guys.
It really does. Absolutely. Thank you, Dr. Ferguson. That is so very true. So injury prevention is another critical component, right? So this is where public health and trauma systems interface. So in the world of trauma, it's viewed as a disease, right? Just like cardiopulmonary disease, asthma, right? And so diseases we think of as preventable, just like traumas are preventable. So we look at common causes of injury, commonly injured groups, and target outreach to them. This again requires the use of the trauma data. So again, research is so important, and then focuses on publication. So, public education. So these are some examples, right? Gun safety, car seat safety, helmet safety, seatbelt safety, please don't drink and drive. Those kinds of, all the public health stuff we've seen all of our lives comes from this. All right, so now we're going to talk about trauma field triage, right? So important what you guys do. So statistics. Unintentional injury is a huge leading cause of death, especially in young people, mostly ages 1 to 44. And this is data from 2017. So there was 250,000 deaths related to injury in the US, 43.2 million ED visits. Granted, this could be, trauma could be a scratch, you know what I mean? Like a laceration to your hand. This wouldn't be necessarily ones that called 911 for y'all, but 17 to 28 million EMS trauma activations. That's a ton. That's so much. This is so much of what you guys do. And you do it very well. So the history of trauma field triage, right? So in 1976, the American College of Surgeons, the Committee on Trauma, they published some generalized guidelines, like some resource documents, like this is how we suggest y'all do it. So this is both for pre-hospital triage, but facilities, right? So starting to designate trauma centers, right? Realizing that this was such a huge part of what you guys did and what the injuries that we were seeing, the calls that we were getting, realizing that we needed to kind of start coming up with an organized system to address this. So in '86, they formally published the field triage of injured patients. That was revised multiple times. And then in 2006, the CDC and the National Highway and Traffic Safety collaborated with the American College of Surgeons and convened like a national expert panel. And then in 2009, they published their documents, which have been revised several times, the most recently in 2021. So it's a lot goes into it. So accuracy is so important, right? Accuracy is the degree of triage, right? The match between severity of injury and the level of care. This is really hard to do sometimes, right? Depending on, the populations, the very young and very old, they can trick you. They trick me in the hospital all the time. Patient differences, like I just mentioned, occult injuries, things that aren't obvious, right? Like Dr. Ferguson was just saying, that's why we have, and we'll talk about the, stage 1, stage 2, all the different ways we triage traumas. But we leave a little caveat in there for EMS provider gestalt. If you think something's wrong, we trust y'all. You see a lot of traumas. We trust that. And just like the story Dr. Ferguson said, there was something really wrong with that patient because you guys recognized it. And you couldn't necessarily say, oh, it's vital signs. Oh, it was mechanism. It didn't meet any of the criteria. But there's just a little door left open for you guys to say, I don't feel comfortable with this, right? And that's because this is so challenging in the field sometimes. And then complexities of patient assessment in the field, right? It's hard to see all the injuries on a dark highway at night, right? In a ditch, right? And then the concept of under and over triage, which we've already discussed. Again, like Dr. Ferguson reiterated, like we really want to emphasize we are okay with over triage. We would rather have over triage than under, right? We're okay with dealing with a few MVCs that have no injuries to make sure we don't miss somebody who has a serious injury. All right, so step 1, physiologic criteria. So this is the formal trauma triage schemes, okay? So this is vital signs and level of consciousness. So anyone who's a GCS equal to or less than 13, systolic blood pressure less than 90, respiratory rate less than 10, greater than 29, less than 20 for a pediatric patient under a year old, and if they require any type of ventilatory support, right? So, I mean, could this be someone who's an alcoholic that got into a MVC at a low rate of speed and they're drunk and they're, their blood pressure runs low, can that get activated? Absolutely. Do we see that all the time? Absolutely. Are we okay with that? Absolutely, right? Because we could miss something. We don't want that to happen. So this is the first scheme, the first filter you guys go through, right? So next is anatomical criteria. So if you go through your physiologic criteria and they don't meet it, none of those check boxes get checked, then we go to anatomical criteria. Any penetrating injury to the head, neck, torso, or extremity proximal to the knee or elbow. So if you have a GSW to the lower leg and they don't meet any other criteria, they don't necessarily need to be trauma activated unless you think they do for some other reason that we're not seeing. Any 2 or more proximal long bone fractures, so humerus, femurs, any crushed, degloved, mangled, or pulseless extremity. So say that GCS or that gunshot wound to the more distal leg doesn't have a pulse. Well, then now they're trauma criteria, right? Now they meet trauma criteria. Amputation proximal to the wrist or ankle, any suspected pelvic fracture, any open or depressed skull fracture, or any kind of paralysis in any way related to any kind of traumatic injury. Okay, questions about any of that? All right. Okay, and then step 3 is going to be mechanism of injury. All right, so this is going to be falls. So for adults, greater than 20 feet, right? So it's about 2 stories. For peds, greater than 10 feet, 1 story, or 2 to 3 times the height of the patient. Okay, So if you got a patient, a little one who's only this tall, right? They fall from here, that can meet trauma activation criteria. So you have to be kind of careful with that. For MVCs, intrusion greater than a foot, 12 inches into the patient compartment, into the box, or greater than 18 inches in any site, okay? Any ejection we want to see. And then if there's a death, obviously, in the passenger compartment of the same vehicle, right? So if they look fine, vitals are fine, they're not complaining of anything, but the person next to them is a death in the field, they've got to come. They've got to be seen. And then anytime a car hits a pedestrian, a car hits a bicyclist, right? If they're thrown, run over, or greater than 20 miles per hour impact, anytime that occurs, they need to be trauma activated, or an MCC, a motorcycle collision at greater than 20 miles per hour. Is it hard to gauge how fast, right? Like, how do you know they're going 20 miles an hour, 10 miles an hour, 30? That's hard, right? So it's kind of a weird, arbitrary number in there. So we just do our best to guess, right? And sometimes there's other clues, right? How far was the motorcyclist from the bike? Was their helmet on or off when you found them, right? So there's other things that you guys every day kind of think about when you're going through these triage schemes in your mind, right? This gets really complex. But again, always err on the side of over triage, right? And then special considerations. So high risk populations. And then this is where the EMS provider gestalt, your feeling, comes in. So older adults, they trick me all the time. I always, when I'm taking care of an older person, I just have a higher index of suspicion. And it's because they're tough, right? Old people tend to be pretty tough. I had a lady not too long ago who had a fall that didn't seem that terrible. Maybe it was a ground level fall. I think it was like a step or two. Her son brought her in. Again, she did not want to come in. She had a dislocated shoulder. She had multiple broken ribs, and she had a pneumothorax. And she was yelling at me. She wanted to go home. She was like, I'm fine. I want to go home. I'm fine. I'm fine. I was like, ma'am, you are not fine. You are actually going to the trauma service now, right? So older folks tend to be pretty tough. And sometimes they can have injuries that are not obvious. So that's why they're in this special considerations, right? Because they can have injuries that are not obvious, and they tend to be tough people. And young people, pediatrics, we all know, right? They compensate and they compensate until they don't, right? And so sometimes, you know, we just have to be, our index of suspicion, right? We just have to think a little bit more critically in those kids, in those populations. And then patients on blood thinners, right? Any trauma patient, we always want to ask that question. You hear us ask it in the hospital all the time, right? Are they have blood thinners? Blood thinners. We're always asking you guys if you know, because they can have significant bleeding with a pretty low mechanism, right? And, you know, older folks, right? They tend to be more medically complex. They're the ones that are most likely to be on blood thinners. And so sometimes really insignificant MOIs can cause really serious injuries in these folks. And then burn patients, right? So we really want to think about like the significant, like how bad is this burn, right? Does it need a burn center? And there's criteria, right, that we need to look at. We're not going to talk about specifically today, but there's criteria that'll help guide you. And always, you know, the trauma care center will help you. And then pregnancy, right? So pregnancy greater than 20 weeks always should always be entered in the trauma system. So if you palpate, if you press on a lady's belly and you feel a uterus at the level of the belly button, that's 20 weeks, right? So that's a nice, easy way. If you feel it right here, 20 weeks, that's it, okay? And then again, the caveat we've talked about multiple times, which is EMS clinician judgment, right? So sometimes patients don't meet any of these, but still you guys are worried, okay? And we care about that. We trust you guys. You do this, you're out in the field. We're not all the time. So if you see something that makes you uncomfortable, we're not going to fault you for entering them in the system, okay? And sometimes, like you'll hear, it is a balance of resources too. So to trauma activate someone, to go through our trauma bay at UAB takes a substantial amount of resources, right? Personnel, equipment, right? And that means money, right? That means money. There's a lot of money, and I can't remember the exact number, but thousands, to the tune of tens of thousands of dollars. Tamika back there right now. But tens of thousands of dollars to go through our trauma bay at UAB. Sometimes we find things, sometimes we don't, but right? So it's always a balance, resources versus patient need. But we always want to make sure we're not missing things, right? Morbidity, mortality of our patients is the most important thing.
So I'm going to interrupt again. So who
Yes,
here has taken a patient to the hospital and been fussed at by the staff, doctor, nurse, or anybody? Who has not been fussed at? Raise your hand, because I'm going to come work where you work.
I can't raise my hand there. I've been fussed at, and I'm one of them.
So I guess my point to that is you're going to get fussed at no matter what you do. you're better off overcalling than undercalling these people. We expect about a quarter of these patients not to be significantly injured, and we're fine with that.
Yep.
We'd rather do that than you undercall and there'd be a bad outcome and you feel bad about it and the patient have a bad outcome.
Absolutely.
So the categories she mentioned are important. So elderly people, they don't have much reserve. So if they're injured or jacked up, always err on the side of probably pushing a little bit harder to get them in the trauma system. Okay. People on blood thinners, don't smile at me. You may,
It's all good information.
right.
It's good.
And then the other one I want to mention is folks who are intoxicated or drunk.
That's
Those
true.
guys, I've seen folks come in with open femurs, legs missing, drunk as dirt, and they don't really care about it. So, you know, the drunk folks can really bite you. So do a good, quick assessment on those guys.
That's the truth. They will literally bite you as well. So be very careful, right? I'm sure we all have those stories, especially in Gardner. But yeah, Dr. Ferguson makes excellent points, right? So to reiterate all of that, right? It is important. And I did not include intoxicated patients in my special populations, which I should, and I will update this PowerPoint because that is very true. You know, I just worked Talladega the other weekend. There's a lot of intoxicated patients, and they don't always remember what happened, right? So you're looking for signs of external trauma, abnormal vital signs. Sometimes those are your only clues. But I agree, those should be patients where you have a really high index of suspicion. Your threshold to activate the trauma system for them is lower. They also tend to have low reserve. They don't take care of themselves as much if they're chronic substance users. So all very good points. So say you've made your decision. I'm activating this patient. This patient's going into our Alabama trauma system. So they will assign you, and again, you guys know most of this, right? They'll assign you a unique number for that patient, okay? They will collect some information from you guys. And they can provide you, I mean, they're looking at all this stuff right in front of them. They can provide you with information on protocols, right? Procedures, right? All the things that you need to do in the field. If you're unsure about something, ask them. They are trained to help you with these things. They can give like real time, minute by minute information about the functional status of all hospitals. Have you guys seen that board where it's like green, green, red, red? Looks like little building blocks. But that's what they're looking at. And it tells them what subspecialties are available, who is on diversion, who's not. And so if you work with them, they'll make sure they get you to where you need to go, right? The best definitive care for your patient. So again, coordinate patient destination, and then they will let us know that you are coming, which is so important. We appreciate that so much. So we can have everybody ready, right? I've got my equipment ready. I've got my PPI on. Gloves on, like we're ready to go. We got anesthesia, we got trauma, we got emergency medicine, we've got our Belmont primed, like we're ready. Because time matters, right? We know time matters in these patients. And then they will record and enter pre-hospital data for our data collection, right? To help us get information to kind of improve outcomes for people in the future. All right, so this is just our regional, our BRIM's like trauma plan. So if anyone wants to nerd out and read that stuff, I included it, right? So this is a lot of the very technical and detailed information about what we're talking about today. If anyone wants to do a deeper dive. Oh, that's it. I was a little faster than I thought, y'all. Sorry. Okay. Questions, comments? Nothing? Very clear and succinct. That's what I like to see.
So what level 1 center do we have in Birmingham?
In Birmingham?
Yeah.
Oh, okay. Are we asking them?
Are you?
Oh, me? Well, UAB is a level 1 trauma center. And then we have a lot of level 3s, I think, right?
Right.
Yeah.
Yeah. So I think that St. Vincent's East and Princeton do a lot of the backup. You know, obviously there's Grandview, there's Brookwood.
Yeah.
There's St. Vincent's
Brookwood's
downtown, but
great.
East
Yeah.
and Princeton do a lot of the backup. So one thing of note, so as far as trauma designation, the freestandings are not in the trauma system. They are in the stroke system. So you can take a patient with a stroke to a freestanding, but STEMIs you can't do and traumas you can't do. Obviously, the freestandings don't have a lot of blood products. They have enough just to say, yeah, here's some blood, have a nice day.
Yeah.
But that's about the end of it. But strokes we can do with the freestandings, but none of the trauma stuff. So
Gotcha.
questions, comments, statements within reason?
Okay.
We did have a couple of comments online
Oh, great.
about, all of them are about the same subject, which is, what about the fall from standing with AMS, essentially is what it boils down to.
Yes.
So these are usually neuro patients, I think,
Yeah.
or they could be, cardiovasculars or wide array.
Absolutely.
But there seems to be a lot of pushback from the trauma service when we
Yes.
enter those patients. And so if you could speak about how we decide when to enter somebody and not.
Yes, so I agree. I know exactly what these folks are talking about, because working in the Bay, like sometimes you may get an older person, middle-aged person, who is a fall from standing on a blood thinner or not, right? And they have run through our trauma bay. We don't see any traumatic injuries, but then we realize, oh, they're not moving one side of their body. So they had a stroke and then they fell, right? Which subsequently, and they're altered, right? And which subsequently led them to be entered into our trauma system. So it's a good conversation to have because, should they have not been entered in the trauma system, and so maybe they went medical, hopefully we'd recognize that they were having stroke-like symptoms, they would still get an immediate head CT, but they had a fall from standing, they're on a blood thinner, they meet trauma activation criteria. And Dr. Ferguson, please interrupt me if you disagree with anything I'm saying. But if they meet trauma activation criteria, I think it would be a mistake to not enter them in our system. If we run them through the bay and we do not find any traumatic injuries, then I have personally admitted those patients to then a medicine service, right? So we do our job, which is ruling out traumatic injury, okay? And then they go to the medical ICU or our just floor medicine service if they're doing okay, or neurology, right? We'll get them to where they need to be once they're at the hospital. But for you all in the field, it gets very complex and you may get fussed at, and I am sorry for that. But if they meet trauma criteria, even a fall from standing on a blood thinner, that technically, they should go in the system. So if Dr. Ferguson, if you disagree.
Yeah, I agree. No, fall, ultra status on blood thinners, call TCC.
Yeah.
And they'll get you where you need to go. A lot of things can cause that. They can syncopize and hit their head or stroke. But still, currently, that's the guidelines that the trauma system wants to use.
Right.
Now, it did change recently. In the past, if I was working at a small community hospital and I had a patient that fell and hit their head, I could call and put them in the trauma system and get them transferred easily somewhere to, Montgomery, to UAB, to Huntsville. That's changed for the hospital side. Now you have to kind of work them up and figure out what's going on. But for pre-hospital, fall from standing on a blood thinner, that's a TCC call every day.
Right.
All right.
And arguably, that patient, whether it's traumatic or not, has something really significant medically happening and should be at a large tertiary center. Because if they don't need trauma, maybe they need neurology, right? Maybe they need a medical ICU. Maybe they need cardiology, right? Maybe this was a syncopal event and they're having some, very dangerous arrhythmia that we need to talk to cardiology about. Maybe they need a pacemaker. So there's a certain rate of over triage we've talked about many times that is acceptable. This is an acceptable patient to over triage. And so maybe trauma fusses at you, sorry, but they still may need higher level care that they can only get at a level 1, a tertiary trauma center, right? It may not be trauma, but it may be one of the other specialties. So at the end of the day, it's still the right thing, even though in the bay, you might get fussed at a little bit.
Yeah, unfortunately, in our job, whether it be you be an EMS provider or an ER doctor, you will get fussed at by your colleagues. And that's just like marriage, right? You're going to get in trouble no matter what you do. So just call it a good day. Do the right thing for your patient. Yeah. So if somebody passes out, smacks their head, and they're on blood thinners, what's our big concern? Head bleed, right? So either a stroke that made it happen or something made them fall over and they smacked their head and now they got a blood in the brain. If they're on blood thinners, if you get to an academic place or some of the larger places, there are medicines we can give to stop that bleeding. Just like we have drugs to make you kind of free bleed if you have an ischemic stroke, we can give you medicines to reverse your blood thinners. But that's got to be done pretty quickly. So if you got blood in the brain, we got to stop that so you don't have a bad outcome. So it's very important to get these folks in.
Yes.
Other things to think about head injury. We don't hyperventilate our head injuries anymore, right? We used to talk about you hyperventilate them, you blow off CO2, decrease swelling in the brain. Yeah, it kind of does that. But when you hyperventilate, it causes vasoconstriction. That's how it decreases edema. And that vasoconstriction makes the rest of the brain that's not injured start dying off. So you really kind of defeat the purpose. So we don't hyperventilate these folks anymore. If you got to intubate them, you bag at a rate of 8 to 10 a minute. If you're using a BVM, the same thing. Even if their SATs are 96, 98%, they get O2. You want to make sure these guys are very well oxygenated. You don't want to have any hypoxia. And then the other thing is if they're hypotensive, we want to fix that because hypotension is bad in a head injury. So they get IV fluids, right? If you're doing critical care stuff, you think about doing push dose epi or norepi to get their blood pressure up. If you have a polytrauma patient with a head injury and you got busted ribs, a collapsed lung, a ruptured spleen, the surgeon can fix that. What we can't fix is brain injury. So we got to protect the brain. So
Awesome.
What else you got, Chief Ward?
Yeah, so we got a couple questions come in. One is your thoughts on in the Birmingham metro area, so I guess probably Brim's region. You got a trauma patient, you can't get an airway or you can't stop external bleeding. Thoughts on stopping at a community hospital or a freestanding ED? That's question number one.
Okay.
Question number two is children's a level 1, which obviously it is for pediatrics.
Yes.
Follow-up question, so what age?
Oh, that's a good question. All right, so I'll answer the second one first. I think it's a little bit easier. So 16 is the cutoff, right? So at 16 years of age and older, they can go to the adult center. Okay, 16 and right, 15 and younger, they'll go to children's.
Yeah. Talk to TCC. There's sometimes that some of those 16 or older will end up at UAB as well. Some of the injuries, some of the penetrating stuff, they like them at UAB at Maine instead, but talk to TCC and they would direct you. So early discussion with them so you know which turn to make to get where you're going.
Yep.
It depends. Yeah, talk to TCC. It depends.
Yeah, TCC will always help you get you to the best place for whatever patient you have. Okay. And then for the the first question, so that's going to be really situation specific, right? So if you can't get an airway, maybe a flight medic is on the way who's going to try, right? Is the patient, if their sats are dropping, if they're altered, right? If it's just a question of airway protection, right? And, that is a very kind of call by call question to answer, you know what I mean? But know that if you think this patient needs a definitive airway and you can't get one, right? If they need to be stabilized, right? You can always stop at any hospital along the way and get some help. That is always available to you.
Yeah, so if you can't oxygenate and you can't ventilate, you got to do something, right? So if you got a hospital 5 minutes down the road or 30 minutes down the road, you don't have a choice but go to the 5 minutes, right?
Yes.
Always freestandings. All other places have blood as well. If you got uncontrolled external hemorrhage, that if you don't have a tourniquet for some reason, you should have a tourniquet or you're going to be in trouble.
Yeah.
Then you need to do that. But in reality, it's better to get them to definitive care. But if someone doesn't have an airway, you got to fix that.
Yeah.
Right. You got to fix that. Same thing in medical cardiac arrest. If you don't have an airway, then you're going to have to start thinking about moving earlier than you normally would in the medical stuff too.
Yeah.
The state is working on rescue stops. I know we've done those in the past, and that's where if you're working out in a community and there's a community hospital that is, 20, 30 minutes there, and the trauma center is, further down the road and need an airway, or you think this patient needs blood immediately or something, you can put them in the system, stop at that community place. They will come hang the blood, intubate the patient, tap you on the back, and you keep on trucking to the hospital. So we're working on that. But the way you get that help is through TCC to get that started.
Yeah.
The other thing to think about is always have a plan. So if you got somebody that you're extricating and it's going to take you 20 minutes to get them out of the car and they look jacked up, maybe you start that aircraft coming to you and you think about getting them there. And I know people talk about the time benefit of aircraft flying versus ground. Well, by the time they land, we get them in, we could be at the hospital at the same time. But what does most helicopters carry that you guys don't carry yet? Blood, right? So there is a benefit to that, right? So they are bringing a little bit more advanced technique, procedures, blood, RSI on the field. So kind of have those plans and have a aircraft that you use, have a backup aircraft you can call, and have a backup plan when the weather's bad or nobody can show up, okay?
Awesome.
Yep, so I'm getting text messages saying to remind everybody that if you're going to stop at a community hospital for level 1 trauma, the patient really needs to be in the trauma system. So if you don't enter them in the trauma system, then that community hospital has to enter them to expedite transfer to the trauma center, and it really slows down the care. So that's one of the points of the trauma system is it expedites transfers, and we're not real familiar with that in the field. Dr.
Right.
Ferguson, if you could elaborate on that process.
Yeah, I mean, in this area, it doesn't happen a lot, but you got to put them in the system. You got to talk to TCC to direct them. And that's how you can do that rescue stop. If you're out in the community, you can stop at a community shop, get your blood, get your airway, and keep moving. But you got to use TCC to coordinate that, because there's some days that the UAB, believe it or not, is full and there are no trauma places to go. There's some days that Chattanooga's full and Grady is full, everybody's full. And the sooner we have that information, TCC can start working on finding the appropriate place for that patient. Or maybe you have a trauma patient and then another agency down the road's got 3 trauma patients. So the sooner we get that information, the better. One of the things when we had the state survey by the American College of Surgeons, I forgot the an acronym, sorry. One of the benefits that Alabama has is we have TCC. There's no other state that has a complete statewide trauma system entry way to look at patients, divert them, get them where they need to go, and then go back and pull that patient up and look at the care at the field level and at the hospital, at the rehab, and at home. And like Dr. Willet-Caldwell, saying your name correctly, right? Like she said earlier, I'm not a research guy. I'm not a big data guy. Y'all know me. But if we don't get good data through this, there's no way we can get better funding and get better techniques and move things forward. I think we all know that our system is being challenged at best right now, if not almost at a point of collapse. So we got to have this good data, even though it's complicated, so that we can change things and get funding.
All right, good deal. I think we covered all the questions that have come in. Hey, if you're listening online, please remember to click the link in the chat box to fill out the attendance form. The password for the form today is Triage, all lowercase. If you're here in person, there's some flyers around. You can scan that QR code and get you to the attendance form. And Doc, y'all ready to take about a 10-minute break? We'll take about a 10-minute break, and then we'll be back with you for some more lecture. Hey everybody, welcome back. So for the next lecture, we have Dr. Willet-Caldwell again, and we're still talking about triage, but this time it's a little bit different flavor. This time we're going to be talking about triage on the scene or for mass casualty incidents. Is that right, Doc?
Yep, we're going to talk about incident command structure and a little bit of history, and we're going to end with triage.
Awesome. So if you're listening online, please remember to catch the link in the chat box to fill out your attendance form. The password for today's class is Triage, and if you have any questions, ask them there, and I will relay them to the docs for you.
Perfect. Thank you all again for coming in person and online. If you're just joining us now, my name is Dr. Melissa Willet-Caldwell. I'm an emergency medicine doctor and an EMS fellow at UAB, and we appreciate your time and attention. If anyone has questions, please go ahead in person, interrupt me online, type it in, and Wes will get them routed to us, to the group, to me. And let's get started. So today, we are going to talk about definitions, considerations for mass casualty incidents, the incident command structure, which is probably pretty familiar to most of y'all, and then triage of mass casualty incidents, and then just a little summary slide. So a disaster, right? A situation in which the severity of damage, the number of patients exceeds the ability of scene responders and the local management to effectively take care of the situation. A multiple casualty incident is numerous patients that doesn't overwhelm your system, right? Mass casualty is a very large incident, many victims, and you often will require multiple services to handle the response. And this will obviously, or often will overwhelm or threaten to overwhelm the capacities of both the local EMS systems, but also local area hospitals, right? So this is a very serious, very large incident. So these are just some of many possible examples. So natural disasters, hurricanes, tornadoes, wildfires, earthquakes, also terrorist attacks, violent attacks, so mass shootings, chemical, biological attacks, bombings, plane hijacking in the case of 9/11, public health. So this is something that people don't always think about, but like the flu pandemic, the HIV and AIDS pandemic, the COVID pandemic was kind of a community mass casualty incident, if you would, that did overwhelm our systems and our resources when it first hit. And then wars are historically a very good example of this. So personnel that are important and often involved are hospitals, healthcare facilities, public health organizations and public safety agencies, fire departments, law enforcement agencies, private EMS, Homeland Security, maybe animal control, certainly 911 dispatch. I mean, there's a lot of people that, depending on the situation and on the scenario, will be a stakeholder in this. So resources, we need a lot of them. Medical supplies, earth moving equipment, mass transportation vehicles, mass housing for evacuation and or treatment of patients, support supplies, food, water, sanitation equipment and facilities, both for personnel, but also for potential, patients, right? So what is needed, right? The scale and the specific type of resources needed will vary depending on what the scenario is. But these are just some examples of things that may be needed, which is a lot, requires a lot of coordination. So the goals, right, to provide a framework, right? So a mass casualty incident plan, right, which should be set up ahead of time, right? Should be practiced, should be ready to go. It will provide a framework for execution of a unified plan and immediate EMS mutual aid response, both for scene and situation management, right? So again, this can vary dramatically depending on what you're looking at. This is a standardized action plan, right? It is scalable, right? So it could be made smaller or larger depending on your needs, and it's modifiable depending on the unique needs of the situation. But ensures utilization of both human and material resources, right? So we need supplies, we need equipment, we need people to distribute, to help, to manage. And it can assist with evacuation, triage, treatment, and transport of patients. All these things tend to be done or need to be done relatively quickly. Decisions need to be made quickly. And so having a plan in place ahead of time is so important. So the plan specifically addresses key resources, personnel, agencies involved, develops policies and protocols to address the daily operations, implementing a data and communication infrastructure that is scalable to size as needed, training and evaluating personnel on protocols ahead of time, and a review process that evaluates previous incidents and implements future improvements, right? So important tenets, right? So when you're thinking about MCI and disaster planning, preparation and training is so important, right? We want everyone to know what they need to be doing ahead of time, or at least have some idea, right? So that's why we do a lot of MCI drills. There's one coming up in Florence next month, because we want to make sure people are familiar and we know how to do this, right? This isn't the time when we want to be practicing new things. It also needs flexibility to respond to a wide variety of situations, right? It can be anything, right? And then a clear structure of command and organization, right? So that's the incident command structure that we'll talk about. It's very important. And then constant reevaluation, adjustments as needed, right? As new things develop, as we fix certain parts of the plan or parts of the scenario, parts of the incident, we need to be able, this is a very dynamic process. So an incident command system, okay, this is a Homeland Security definition, but a good one, a widely applicable management system designed to enable effective, efficient incident management by integrating a combination of facilities, equipment, personnel, procedures, and communications operating with a common organizational structure. It sounds like, oh yeah, that's great, but the implementation of it is very difficult. So we'll talk a little bit about a history of how these things developed. But when people realize very quickly, and as you guys probably all know, this came out of fire service. So you guys know this probably pretty well. But there were wildfires in California and multi-agencies responded. And because they didn't have a good coordinated way of communicating and working together, there was a lot of redundancy. Communication was very difficult. People were setting things up differently. They were setting things up for the same area where maybe one could stay there and someone else could go over here. So that's where this all came out of, is they recognized ways that we could be better at this. And people put a lot of effort into coming up with them. So again, first developed in the 70s by FireScope, California, for managing wildland fires. So different terminology, organizational structure, standard operating procedures between various agencies. It caused confusion, inefficiency, and redundancy. So they kind of reflected on what went well, what went wrong, and they worked from there. So later that decade, the incident command structure evolved into an all risk, all hazard system. So they developed this kind of incident command, and they made it in such a way that it could be deployed for very different scenarios, right? It was set up initially for wildfire and fire management, fire suppression, but then they just kind of took it a step further to apply it to all kinds of hazards and risks. So the National Incident Management System developed in the 80s for nationwide implementation of this kind of incident command structure. Emergency Planning and Community Right to Know Act in 1986 took it another step further, and then FEMA began utilizing incident command structure and incident command management teams for national disasters in the 1990s. So Hurricane Andrew was one of the first ones. Homeland Security, Presidential Directive 5 and NIMS in 2000s. This was a direct response after 9/11. And it became the official national standard for disaster preparation and management. So that's kind of where we find ourselves today. So incident command structure is modular. It's a modular management system, meaning it is broken down into different components, right, for efficiency. It can be expanded or contracted to match size and complexity. And its priorities include life safety, incident stabilization, property and environment conservation. So those are the goals of an incident command system and management structure. So unity of command is an important component, right? So unity of command, I think you guys probably already know this, is that everyone knows who they're reporting to, right? It's a linear structure so that all important information goes up the chain and it is efficiently received, ideally, by the incident commander so that they can make changes based on what each component of the system is telling them, right? It eliminates, ideally, redundancy and inefficiency in communication. It is an important tenet of the incident command system. And then span of control. We're all human at the end of the day. We can only deal with so much, right? We can only manage so much effectively. So once someone who is in charge, and this could be a sections chief, this could be, whoever, and we'll look a little bit at the actual structure of a command system. But ideally, like 3 to 7, right? That's what we think a single human can efficiently manage, right? And so once you get above that, then we start breaking it down into smaller chunks and we get other people to be in charge of different sections. Does that make sense? Cool. All right, so here's an example of an incident command system. So we'll talk a little bit about what each one is, but you have your incident commander, that's your leader, right? Your boss. Your command staff includes public safety, information officers, safety officers, and liaison officers who report directly to incident command. And then you have chiefs of your sections. So it's very standardized. It's always going to include operations, planning, logistics, and then finance or admin. Those are preset in an ICS, always there, okay? Those are considered your general staff. And then after that, it'll be broken down into branches, divisions, groups, and we'll kind of talk about all that as needed, right? So everything below the general staff, your sections can be very dependent based on the situation and what is needed. Yes, sir.
Yep. Sorry to interrupt.
Please interrupt.
Got an interesting question here. So one thing of note for EMS is that treating the victims comes under operations in the form of either task force or strike teams.
Yes.
But treating responders comes under the medical group, right?
Yes.
So my question is, on an incident, is there a role in this structure for the medical director? And if so, where do they fit?
It's a very good question. So yes. So we'll talk about the details of what each section does a little bit later. So this is a little jump ahead, but I'm happy to answer it now. So operations is always where EMS is going to fall, right? So medical care, because the operations section is responsible for carrying out the action plan, right? This is the things we need to accomplish. And if there's patients, that's always going to be part of the operations, right? It's taking care of the patients. And so your medical officer, right, or your EMS director is going to fall under operations under like EMS, and they will report directly to that section chief. So you can, I don't think I have a pointer on this, but if you look to your far left, operations sections chief, right? This could be EMS, which could be further broken down into triage, treatment, transport, and your EMS director will be like right here. So he would be someone in charge of, like, if this was EMS and all the subsections of treating medical patients, right? So your medical, right, your medical officer would be here. Your medical director would be about right there. Does that make sense? Does that answer the question?
Well, it sort of does, but wouldn't you also need medical direction over the medical unit that's treating responders? Like on a long-term event, like a tornado recovery?
Yes, so yes.
And that's under logistics.
That is a good point. I see what you're saying. So are you saying if EMS personnel then needs medical care? Is that what you mean?
Yeah, so responders are treated by the medical unit, which is under the logistics section chief. Victims of the incident are treated under operations by either single resources, strike teams, or task forces.
Correct.
So I understand where you might have providers under operations section, which is where most of the providers will be. My question is really about physician medical directors. And I'm wondering if on a large scale incident, if the physician medical director shouldn't be in the command staff as an advisor, because they can also, I think that would also be useful in a large incident in the planning section for resources. And I don't know, I'm interested to know what the firefighters and the EMS responders in the room think and what the physicians in the room think.
So the structures that I've read about that my understanding is they tend to stay with operations, but I agree, right? So medical unit leader, there is some medical-esque things that happen down here. So I actually don't know the answer to that. Dr. Ferguson, are you our EMS folks live? Like, do you guys have any?
Yeah, so recently, not too far from here, right, we had a field amputation at a tornado event.
Okay.
So the physicians involved in that would be under operations.
Okay.
But coordinating that would be above operations section chief.
That is true.
So usually we don't have physicians involved in disasters. I guess what I'm saying is I think we probably should. But when we do, because we can't have things like field amputations happen without those physicians knowing their role when the time comes ahead of time.
Agreed.
So where is a good spot for them to be? I would suggest in the command staff.
I mean, I definitely see the point that you are making, because there are medical decisions and medical treatment happening at different sections, not just operations. Traditionally, the structure is that the medical director is usually with the operations section. But I mean, I think that's a very good point. If anyone has anyone done any MCI, like live stuff? I know Fields was just here and he does a lot of that. But if anyone has a comment on it, I'm definitely would love to hear it. Because I mean, my understanding is it's an operations section. But I guess that doesn't mean you can't.
I know as part of the Hurricane Katrina response, I didn't really see any physicians except for a public health physician that was at the county command post.
Oh, that's interesting.
Yeah, so there's public health issues to large scale instance as well.
Absolutely.
Like downstream quality of water issues, sanitation issues.
Absolutely.
We've got to set up temporary morgues. We've got to set up temporary pharmacy for the people who are still there.
Yep.
Who need prescription meds.
All those things.
All those things probably could be well guided by a physician.
I agree with that. You know who would be a great resource to help answer this question is Joel Evans, right? Because he's kind of our disaster guy. I don't think he's listening in today online, but I can reach out to him and see if he has some information. Yeah.
A lot of times, in that multiple area command, at the most upper level, there is a position that's there, oversees other positions that are attached down into, the command staff. That's where they are. And even at the command staff level, there may be other positions that are assigned to the operations to handle that. That was the case for Deepwater Horizon.
Oh, I gotcha. Okay. So it sounds like, right, it's not always one physician. Ideally, we'd have multiple physicians, which absolutely makes sense. But they may be assigned to work in the operations section, but there may be medical personnel, medical physicians that are part of the command staff, not just the 3 that are listed here, which makes sense, right? Which makes perfect sense. Okay. Does anybody else have anything else that they want to add? Any other questions about that?
Well, we had a couple of comments come in. The basic here is they should be in triage.
Yes, I agree that we
So
can.
that would be under operations. But I think it really is going to be contextual, right? It depends on the scope and scale of the disaster.
I agree with that completely. Right.
I think a mass shooting looks a lot different from, say, a blizzard response that
Absolutely.
lasts for a week.
I agree. Absolutely. And it depends on scale as well, right? And where
Yeah.
resources are needed, where expertise and what expertise is needed. Because ideally, yes, a physician can be in triage, but you know, if you're doing some basic maneuvers, I mean, you can, any medically trained person could do triage, right? As long as you're not expected to, you know, decompress a chest, if that's not part of your triage scheme, which it often is. So like a paramedic could be doing triage, it doesn't have to be a physician.
Well, I agree with that. I think paramedics should be able to do effective triage, but I'm thinking about the Las Vegas Mandalay Bay shooting.
Yes.
Where you had a variety of community and trauma centers available that were all overwhelmed immediately with the
Yeah.
wrong patients at the wrong place.
Yeah.
And I think that a surgeon would have been, and they probably used surgeons to say, no, this one needs to go to surgery, this one
Yeah.
can stay here, could probably do that more effectively than a
That's really true.
paramedic.
No, I agree with that. I definitely agree with that. But I mean, I think I agree with what everyone is saying where ideally more than one physician involved. Certainly there's a role under the EMS branch of the operations section, 100%. But due to size and due to variability of situation, there's certainly a role for physicians elsewhere in this incident command scheme. Like that is 100% true.
So another question that just came in
Yes.
is, so fire and EMS we're all very familiar with instant command.
Agreed.
The NIMS, we practice it on a regular basis.
Absolutely.
We tend to pigeonhole it into really small scale incidents
Yeah.
and don't get a lot of practice on the bigger stuff.
Yeah.
But the comments and questions are is this included in the training of all physicians? Are physicians
No.
trained on NIMS?
No, not at all. So no. So mass casualties fall under EMS trained physicians for disaster, event medicine. We train on those things. But for even an emergency medicine physician, unless you have a special interest and you want to learn more about it, this is absolutely not a part of a regular physician's training. And I would say any specialty, unless you have an interest.
Yeah, it's not part of the core curriculum for sure. So the EM residents get an exposure to this, but the exposure is a book chapter and a potential one FEMA online course.
Yeah.
Now with the EMS fellowships that started in 2013 nationwide, it is part of that curriculum. There are currently only about 1,000 physicians that have gone through that curriculum in the U.S. And I would say about 60% of those just took the test to get in and actually did not get the training. So we're moving that direction, but we're not there. I think the key point from my side, from my thoughts on this is we just need to be more integrated. Docs need to be involved in EMS. We need to have the EMS providers more involved in the hospital. We need to share data resources. We need to work together. The EMA sets up all this stuff for you guys too in these big events. So we just gotta, we gotta pre-plan, know each other, have contact information, and practice this before a big event happens so we don't get screwed.
Cool. Any other questions? Anything else anybody wants to add? All right. So incident command, one boss, right? So sometimes in large scale incidents, there's unity of command, right? You may have a police incident commander, right? You have fire incident commander. But these are groups of senior representatives from multiple jurisdictions, multiple agencies, and they act as one voice, right? So they come together to give one incident commander voice, although there may be sometimes multiple. They create and approve the incident action plan, and they appoint your section chiefs and your command staff. So your command staff, which is your public information officer, which is the interface between the media and incident command and what's going on to give public information. Safety officer is in charge of safety over the entire scene for both personnel, but also for patients. And then the liaison officer is somebody who coordinates with outside resources. So say we need a bunch of school buses for some mass transport, that would be your person that kind of interfaces with private companies that provide resources for the situation. So they report directly to section chiefs. I'm sorry, they report directly to incident command. They receive information from the section chiefs. And then maybe in the future, we'll get having a medical doctor as one of these people. Oh, we'll be in the future. So sections. So organization levels responsible for major functional areas. These are always predefined, right? So you're always going to have operations, planning, logistics, finance, and admin, right? So if the scale is big enough to require sections, these are what they are going to be, right? Section chief is appointed and reports directly to incident command. And then groups are functional areas of operation, a specific function, not predefined, based on the situation needs of each incident. So some examples might be ventilation, water supply, treatment, transport of patients, right? Triage. Led by group supervisor, reports directly to the section chief or branch supervisor, depending on the size. Divisions are geographic areas, right? So they perform independently of each other, like first floor, second floor, north-south areas. Again, not predefined based on the needs of each incident. Led by division supervisor, and just like groups, they report to the section chief or the branch supervisor, depending on the size. So branches are used when the number of groups or divisions exceeds the span of control of the section chief. When there's too much for somebody to reasonably keep track of, we'll start breaking it up into branches and have different people in charge of each branch. So units, functional responsibility for a specific incident planning, logistical, or financial activity. Resources defined as an individual or equipment available to assign for assignment for these incidents. Task force, combination of a single resources assembled for a specific tactical need. They always have common comms and a leader, and same as strike team. So combination of the same type and kind of resources with common comms and a leader. So now we kind of talked about that. When we go back to this, kind of just makes a little bit more sense. Questions about any of that before we go forward? Any online questions?
Yeah, so we just have a continuing discussion about the system as it affects healthcare.
Awesome.
Got one comment. Well, hey, isn't HICS required for everybody at the hospital, or at least hospital administrators, hospital incident command?
Oh, so I would say probably for leadership, right? For leadership and administrative, most should be at least familiar with this, right? So every hospital should have some sort of protocol in place for if a mass casualty occurs, and the hospital should train on it just like EMS trains on it. Like they should be familiar. So Dr. Ferguson?
Yeah, so I think the point being made by some of the online listeners here is, hey, why aren't all the healthcare people required to get the NIMS training just like all first responders are, so that we could all be on the same page?
I don't disagree with that comment. I think that it is important, because if you have, so in my time at residency, we had, I can't remember what it was a tornado. I can't remember what exactly the situation was, but text messages, phone calls went out, like, if you're available, please come. We need people, right? But prior to that, there's no specialized training that the worker bees get, right? So administrative people that are more stakeholders in this, nursing management, the physicians that have an interest in emergency medical care, surgeons, right? People, anesthesia, like, so their leadership, they have plans in place, but it does not necessarily get disseminated to the worker bees, right? So the people that work in the hospital. And so should something happen and we need people, there will be a briefing, there will be information released at that time, but there is no specific mandatory training ahead of time. And I think it's a reasonable question and a reasonable conversation, right? Because things that happen in the field, you guys are trained on, you do very well, but secondary, tertiary triage, those things occur when you get to the hospital. And it would be helpful to have at least some familiarity from the worker bees, I think, the people in the hospital that are doing this work. Dr. Ferguson, you look pensive, like you're ready to say something.
Oh, no, it's just the same thing. It's, the hospital EMA organization, I know there's a group of the folks that run the emergency disaster drills, hospital leadership, ER leadership, those guys get some of this training as well.
Yeah.
But like you said, like most things, the training doesn't trickle down to the daily workers. I think the hopes to that is that if there is a big event, the leadership, just like with the fire or police or EMS, will be available to help kind of direct and make that work. But it goes back to a point that we've said at EMS Challenge for a long time is you got to train for these things, right? You can't just do a drill every 4 years and think you know what's going to happen. You got to make sure everything works, make sure the current leadership knows what's going on, because there's a lot of leadership roles that are changing here. So I think that's the key point to that.
Yeah, absolutely.
Yeah, so we had another comment online that kind of reinforces, I think, everything we're talking about. Just somebody mentions that they were deployed for COVID to New Orleans, and it took several days were spent training nursing staff on ICS before anything could actually get done.
Yeah.
So I think that just reinforces the point. Maybe we should all do the same training.
Yeah.
When it comes to command structure.
Yeah, I think even just having a basic understanding of terminology, right? Procedures, just having, even if you don't know it in detail, but just to have some familiarity would be very helpful. It would be helpful. So I agree with that. I think in an ideal world versus the world we live in, right? There's definitely some strides that need to be made for sure. But I agree completely. I think in this, when it actually happens is not the time when you want to be scrambling to prepare, right? That's why the people that do have a stake in it, that are the most interested, y'all do prepare, you do plan, you do train for these things, but unfortunately not everyone gets the same training that you guys do. It would be beneficial if we did. All right, and thank you guys for all your questions and comments. It is appreciated. Okay, so we're going to talk a little bit about section responsibilities, right? So the operations section is responsible for carrying out the strategic plan approved by Incident Command. So EMS, fire suppression, evacuation, hazmat, right? There's also a staging component to this where everything, all the resources are there and ideally they're ready to go, being staged, ready for deployment as needed. The planning section, they do continuous reassessments of the situational aspects, right? As things are dynamically changing in real time, they make predictions for likely scenarios that will be encountered. They monitor resources, they take care of documentation, and they will draft the action plan for IC approval. So these branches are situation, resources, documentation, demobilization, right? So when everything's wrapping up, how are we going to have a plan to efficiently back away, right? When we're wrapping everything up. And this is the branch that typically includes a lot of technical specialists. So say you have a bridge collapse, right? You might need a lot of engineers. You might need a lot of structural people that specialize in these things, right? So logistics, typically 2 branches, right? And they are responsible for communication, basic support for y'all. And this goes back to the question, right, that we had initially about, do physicians help with this? Because we are caring for EMS personnel, which could become patients, right? Equipment, including maintenance, repair. So branches are service and support. They work closely with the liaison officer. So he's one of the officers, the command officers that are working with outside private companies to make sure we're securing the resources that we need. Finance, that's kind of a little self-explanatory, but they keep a lot of records on personnel involved. Unfortunately, if there is a death related, so if we know that you're working, then this is the department that's going to make sure it is known that you were there and your beneficiaries receive what is owed to them. They keep track of periods worked. They also manage budgets and project costs, estimates, and anticipated costs of resources needed. So time, procurement, comp and claims, and then cost are all branches of this section. Questions on any of that? No? Okay. So now we're going to talk a little bit about triage, right? So triage in a mass casualty incident, you need a system that allows you to make rapid decisions, right? Something happened and you've got to feel the people that all need your help, and we need to do this quickly. And a big tenet of MCI triage is ensuring the best possible outcome for the greatest number of people, right? So this can be very difficult because a patient that, should you have ample resources, might get a lot devoted to them. We might work hard to try to keep that patient alive. In a mass casualty incident, they may be deemed expectant. We don't have the resources because this person needs life-saving, right? They need an OR immediately, and maybe we're not able to get them there. Or they need a lot of care that we just can't provide given the situation that we find ourselves in, which can be emotionally difficult for people, right? So this first came out of military organizations and was extrapolated to use in civilian areas. And this is used when the number of patients outweighs the immediately available resources. It is a form of prioritization. So triage literally means to sort, right? Or select, and you put them in categories based on some physiologic categories that we'll talk about. So the primary triage occurs in the field. This is when you first lay eyes on your patient. You may, or someone from your team may also be involved in secondary triage when you're reassessing them a little bit later, right? So the walking wounded may get moved, and then someone again will reassess that. That'll be a secondary triage. And then they'll get re-triaged again when they hit the doors of the hospital, right? So ideally this will occur kind of over and over and over again. So there's many schemes that exist and may differ per local agency. What y'all use may be different than what somebody else is using next state over. So Model Uniform Core Criteria, MUCC, was developed to ensure that we have minimum standards, right? That everyone's at least somewhat doing the same thing. The Federal Interagency Committee on EMS approved this MUCC as national guidelines in 2013. The National Highway Traffic and Safety Administration added an addendum that EMS must be trained on this in 2017. And then the CDC, somewhat recently in the last few years, kind of reviewed all available kind of triage schemes that were widely used. 2 were PEDS specific, but there was 9 overall, and they reviewed them and did some research stuff. And then after looking at all of that, they developed SALT, which is a form of triage that is, after they reviewed supporting literature and reviewed all the different trauma triage mechanisms, they came up with SALT, and that is what is recommended by the MUSCC. So triage categories. So you guys probably know all about this, but first is red. That's immediate, an obvious threat to life or limb. This is patients in respiratory distress. They're actively hemorrhaging. They may be unresponsive. They're altered. They have anatomical or physiologic criteria that indicate that they are very critically injured, okay? So delayed or yellow, need definitive medical care, but they are unlikely to decompensate right in front of you. We have a little bit of time, okay? So deep lacerations, but good CMS. Maybe they have open fractures, abdominal injuries, but their vitals are stable. They have a head injury, but they're alert, and they have an intact airway. You've got some time. Minimal or green, these are walking wounded, right? They were involved, maybe they got some abrasions, contusions, some small lacerations. They've clearly been in some sort, they're injured in some way, but they can tolerate extended delays. These patients, they are the lowest in your triage scheme. Patients that are dead or black, no respirations after some basic airway maneuvers. They have obvious signs of death. These may be decapitated, maybe very obviously dead folks. And then expectant is gray. they may still be alive, but have little or no chance for survival despite maximum available therapy. And the key there is available, right? So this may be a patient that might be scooped up, all resources given, and haul ass to the hospital. But in the scenario you find yourselves in, you don't have those resources, right? These are severe injuries that are non-survivable or require rapid surgical intervention. That's not possible, okay? So they get a gray tag. All right, so this is SALT. Sort, assess, life-saving interventions, right? Treatment, transport, that's the acronym. This is an MUCC compliant triage system. This is an all hazards, so this can be applied regardless of the scenario or the MCI situation. And this is for all patients, pediatric, adult, and special populations, right? So really you walk up and you say, everyone that can hear me, if you can get up, walk over there. People that get up and walk over there, those are your greens, right? For those of you that cannot get up, raise your hand, wave your hand, okay, right? These are people that might be your delayed, right? They have more significant injury, but that gives you a lot of information about their mental status. They're following commands, right? They can hear you, right? So you may have to help them up to where they need to be, right? They're delayed. And then the people that do not move, do not speak, those are the ones you go to first, right? Because they're either going to be your reds, your blacks, or your grays, right? So those are the patients that you see immediately, right? So now you're at individual assessment, step 2, right? So you do some basic life-saving interventions, right? If there's some major bleeding, put some pressure, you put a tourniquet on it if it's in a spot where you can do that, right? You open the airway, right? So jaw thrust, open that airway. If it's a kid, you can give 2 rescue breaths, right? And you can decompress a chest if you feel like it's necessary. If you do any of those 3 things, right, and it does not work, you walk away from that patient, which is a very difficult thing to say, right? Next. That's sad. So if you do those things and they start breathing, right? If they can make any kind of purposeful movements, obey commands, right? Do they have a pulse? Can you control hemorrhage, right? So if all of those are yeses, and they have minor injuries only, right? Then you go, why didn't you get up and walk? Or why didn't you raise your hand? First you say that, and then they get appropriately triaged into green or yellow. But if any of those are a no, right? If they're not obeying commands, they don't have a peripheral pulse, right? They're in respiratory distress or, major hemorrhage, right? They're, like I said, unlikely to survive. And you have to walk away from that patient, which is not a small thing, right? That is not easy to do, especially for those of us that are trained to help people. That's hard. Questions about SALT? Okay. This is START. This is also commonly used. And sorry, before I keep going, Officer Fields gave me one of his field triage tags. I mean, I'm sure you all have seen it, but if you guys want to look at it, I was going to pass it around. All right, so simple triage and rapid treatment, right? This is very commonly used. It is not MUCC compliant. It is all hazards and it is designed for adult patients, right? So this is very similar, right? You're moving your walking wounded. A very effective way to do that is to say, hey, everyone that can get up, stand up, move over there, right? So you are allowed. So first you will get your greens and your yellows to move if possible. And then the patients that look the sickest, you're going to do individual assessments. You are allowed to do some basic maneuvers, right? You can do the head tilt. Maybe they're breathing, but they're unconscious. If they have, if they're very tachypnic, right? If their cap refill is abnormal or they don't have a peripheral pulse, right? These patients are going to be reds and you're going to try to treat them. Mental status, right? If they can't follow simple commands, everyone else is delayed. But again, right, you have to think of patients that don't have, that have obvious signs of death or don't have an acceptable response following basic things. These patients also will be categorized as deceased. All right, Jumpstart, this is patients 1 to 8 years old. This is the same thing, but it's pediatric. It's also all hazards, but it's just slightly modified, right? So if they're able to walk, right, then you ask, then yes, great, minor, they go off to secondary triage somewhere. Breathing, right? If they're not breathing, you'll position their airway. If you do that and they're able to breathe, they're a red, right? They're still apneic, you test for a pulse. If there is no pulse, then they are considered dead or expectant. And then if there is a pulse, yes, you're allowed to give 5 rescue breaths. If that does nothing, that's it. If they start to breathe with some rescue breaths, again, then their triage is immediate, right? So if they aren't able to walk, but they're breathing, then you assess the rate. They may become red based on the rate. And then a pulse, right? If they don't have a pulse, a peripheral pulse, then they're immediate. And then, sorry, I can't read that. AVPU appropriate, right? Airway ventilation. What does AVPU stand for, y'all? I'm sorry. Say it louder. There you go. All right, so excuse me, but you'll assess that, right? And then based on that, right, if anything's inappropriate, right, then they go to immediate. And if they hit all those and they look okay, then they can go to delayed, right? All right, so for MCI triage, this is for marking your triage patient. So that tag is being passed around. There's also just tape. You can mark on someone's forehead if you're first on scene and you don't have anything, colored tape wrapped around their wrist, and you can physically put patients in different areas, right? This is our greens, these are our yellows, all our reds are going over here. And so just a little bit on the philosophy and ethics of triage. The Agency for Healthcare Research and Quality and the Institute of Medicine, they've published reports on altering the standard of care during MCIs. And this is because it's due to resource limitations that force deviation from the standard, right? We all have a way, that we expect that we're going to care for patients, right? We all want to help people. And sometimes we have to shift that, right? To the greatest amount of good for the greatest number of people. And sometimes that means leaving the side of a critically ill or injured patient, which is not a small thing, right? And then it highlights always the importance of reassessment, secondary, tertiary triage. Patient conditions change, it unfolds, patients get sicker, maybe they'll get a little bit better, less likely, but so that's why continuous reassessment is important. All right, so that's it. So my summary slide is before an MCI, we need to have a plan. You need to practice the plan. We talked a lot about that. During an MCI, having clearly defined roles and clearly defined leadership is so important. Communication is so important, right? Making sure we don't have redundancy and we have efficiency of communication, making sure the people have the proper orders and they know what their responsibilities are, and making sure that important information about the scene and is about things unfold are going up the chain efficiently and appropriately to get to the people that are making the decisions. Reassessing and modifying as your needs change, also very important in these dynamic processes. And then after, debriefing and modifying your future plan based on what you learned also. And then supporting your staff. These are very difficult, physically difficult, emotionally difficult taxes. So making sure your staff, is getting the supplies they need, is getting rest time, right? And has an area to kind of just debrief and talk about what they've had to do and see is very important. That's it. Questions, comments? Oh, how did I do that? There you go. Thank y'all. Any online stuff?
Well, we've had still an ongoing discussion about hospital ICS versus NIMS ICS. And I have to say, I'm not real familiar with hospital or HICS ICF. People are commenting that it seemed to work well when they moved patients to Grandview and during a hospital evacuation up in Coleman some time ago, and so on and so forth. So again, I think that common sense would tell us all that we kind of all need the same training and use the same terminology and have the same understanding of lines of authority.
Agreed.
And we need to do that before a big disaster happens. Yeah. So a lot to work on. I think the key to triage, in my experience, is training. I don't think we train enough on it.
Yeah.
It's just hard to keep up with. And the other thing is the re-triage. Just because somebody's green right now, these things can go on for a while.
Absolutely.
If we look at the number of ambulances that are available for surge capacity, even in Jefferson County, if we had a really mass casualty incident,
It would very
I mean,
rapidly
we
overwhelm.
would have patients on the scene for hours.
Yes, agreed.
And so that periodic re-triage, is there a recommendation for how often a patient is triaged?
Oh, that's a good question. I honestly do not know the answer to that question. I would say as frequently as possible as the resources available dictate, right? So like you said, I agree. Patients who are maintaining can very quickly decompensate. And I would say the rate of re-triage or reassessment should be different for those in the yellow category versus the green category, right? And if anybody else knows the answer, if there is an answer to this, I'd be open to hearing it, but I have not heard of a recommended time course for reassessments. I think it's going to depend on what resources you have available, what the patient looks like when they hit this area for secondary triage, and common sense. Those would be my 3 recommendations for that, but I don't know of a specific scheme. Certainly, yeah. But in the field, I don't know. Yeah, I don't know. Yeah.
I know at field scenes for mass casualty, one thing that always is apparent to me is people will, and drills are in real life, they'll expend a lot of energy to transport patients to a collecting point to be triaged, rather than just transporting them from where they are to definitive care.
Yeah.
And that can be very confusing. And
it can be confusing. It can
manage.
delay
Because
definitive care for ill patients.
Mass
Yeah.
casualties, and I referenced the Las Vegas shooting before.
Yeah.
There really was no scene there. That the scene was spread out over miles.
Yeah.
Because people fled when the gunshots started.
Absolutely.
And people self-triaged and self-transported, normally to the wrong place.
Yeah.
So I think that you have to understand that you have to be flexible in your plans.
Absolutely.
And I think a lot of the hospitals already understand, but you may have to triage inbound patients even after they've been triaged in the field.
Oh, absolutely.
With the idea that your triage may route them to a different facility.
And that's just the nature of the beast, right? So an MCI by definition, right, is a large scale incident that overwhelms the capacity of what we have available to us immediately. So a certain amount of that is expected and should be planned for. And anytime a patient transitions into a different, right, and I don't mean to say level of care, but they need to be reassessed, right? Anytime they go from the field triage, right, there should be somebody when they get cohorted that is kind of responsible for, if available, reassessing patients within their area. If they get transported to the hospital, whether it's an MCI or not, gets triaged at the door, right? So that's already happening. We may run into a situation at the hospital where we don't have enough staff to appropriately triage everyone as quickly as we'd like to, but everyone's going to get re-triaged once they get to the hospital. So those are all very important points. And again, like you said, each scenario is different and requires a different level, different amount, a different type of resources, right? So, and you know, there's always going to be some element of error, right? Because by definition, we are stressed, right? Our resources are stressed. These are overwhelming situations, and room for improvement, right? So that's why we plan for it. And that's why we have plans in place that allow for flexibility, right? Scalability. And that's why at the end you debrief and we figure out what we can do better, right?
Yep. So again, the answer is train,
Yeah.
and train some more.
Yep, agreed.
Someone did mention that there was AMAS training at the Alabama Fire College yesterday and today. So
Hey,
timing for the lecture today.
good timing.
And also from the previous lecture, I did have a text question. Maybe Dr. Ferguson can help answer this. So the freestanding EDs, we seem to be getting more in the area. There's more planned, more
There
coming.
certainly is a couple.
So thoughts
On the way.
on allowing freestanding EDs to be rescue stops, if we should implement a program where rescue stops are available?
Yeah, that would be a question that needs to be proposed to the state. So really can't say yes or no. However, I would argue that in the BRIMS region, you're close enough in vicinity to the trauma centers that you're probably better off just making the drive, and there is no airway.
Right. Unless it is truly a
unless it's
rescue stop.
truly a rescue stop, but that would be a question for the state.
Yeah, and that's tricky too, to even say no airway, because usually by the time you get to a rescue stop, no airway means no pulse. And
Right.
what
I
are we
know.
going to do for traumatic
Traumatic
where
arrest.
there's not a surgeon?
Right. Yeah, that's true.
It is. Those are tricky questions,
It's
right?
it's a bad situation for everybody.
Yeah.
And on the mass casualty, I would argue that when you talk about the triage, that needs to be the most experienced medical provider there, medic. So it may not be the highest ranking officer in a fire service, et cetera. It needs to be somebody with good clinical skills to recognize the sick or not sick and who's going to decompensate pretty quick.
Yeah.
And
Agreed.
then on a smaller scale, we have MCIs every day at every hospital and every agency because we're overworked and understaffed. So for the folks in the hospitals that are listening, just food for thought. You have patients in rooms, you have ambulances on the wall, you have sick people. If you have someone in the room that is less sick or already has a diagnosis and therapy initiated, maybe those people get pulled out, they go to the hallway, and the sicker patient waiting to be seen goes into a room to get evaluated. Challenging days, we just kind of reevaluate and use what resources we have. And unfortunately, those are limited. So
Absolutely.
in the closing, just remember, if you're in the Gardendale area, we're at the Civic Center in the Magnolia Room. We're going to do some advanced airway, ultrasound, mega codes. Come out, train with us. And thanks again to Gardendale for having us. Appreciate you guys. Really do. Chief?
Yep. Thanks, everybody. Please remember to do the attendance form, even if you don't need the CEUs. It's important to us to track how many people we're reaching and to get feedback from you. If the link doesn't work in the chat section, you can always send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the form, and the password for today's form is Triage. So great lecture, Dr. Willet-Caldwell. And also we had another comment that just said, hey, everybody remember, start Triage is actually mandated by the Alabama EMS protocols. So anyway, maybe we should approach SMIC with some of the other ideas as well. Might be able to come up with a better system. But train everybody, and thanks. We'll be at Oxford for our next session, and that'll be on October the 26th. Is that right, Doc? It's a 26th, which is Wednesday. 26th of October, I'll be at Oxford. Right? The fourth Wednesday of October, if my calendar is correct, that would be the 26th, not the 28th, as you said earlier. So just, okay, 26th. Stay tuned. Thanks, everybody. See you next time.